Yes. Okay. Good morning and good evenings for all the audience and our friend in Craniofacial Chang Memorial Hospital webinar here. Today, we are so happy to hold our 34th the ICC webinar with the Professor Supin Tsao. I'm P.Y. Cho. Yeah, so in the beginning, I have to introduce our mentor, Dr. Tsao here. Dr. Tsao has graduated from the China Medical University in Taiwan and finished his plastic surgery residency training at Chang Memorial Hospital. Dr. Tsao completed the fellowship at the Acute Hospital in Toronto and the Jackson Memorial Hospital in Miami and the Mayo Clinics. Dr. Tsao has been the chief of Department of Plastic Surgery at Kaohsiung Chang Memorial Hospital for 10 years, and then served at his own private clinic till now. He never stops to show his enthusiasm in medical education and public service. Dr. Tsao has been the founder and the honorary president at the Kaohsiung Cleft Palate and Craniofacial Association, and has been the founder and the president at the Kaohsiung Aesthetic Medical Tourism Promotion Association. And moreover, he has been the president of the Taiwan Society of Aesthetic Plastic Surgery during 2016 to 2018. At that moment, a lot of great achievement and significant change has been done, including signing several MOU with our friends, such as Korea and Singapore, and re-establishing the core spirit among the plastic surgeons, and build up the educational platform to teach the new blood. Today, we are so honored to have Dr. Tsao come here to share his lifelong experience in reconstructive and aesthetic surgery. The topic is reconstructive and aesthetic surgery on face. So Dr. Tsao, please.
Good evening, everybody. Happy to see you here. Thank you, Dr. Tsao, for your excellent introduction to me. Actually, I am an old plastic surgeon trained from Chang Memorial Hospital. I'm 70 years old now, and I'm the second senior craniofacial surgeon in Chang. I was in Chang for 14 years, including Linkou and Kaohsiung Chang. And then I moved to my own private practice for 25 years until now. When I was in Chang, my specialty was craniofacial surgery, including the crypt and palate. When I was being in my own private practice, my specialty, of course, is aesthetic surgery. So today I'm going to present my topic, including these two categories, that is reconstructive and aesthetic surgery on face. Let me show you. First of all, I'm going to talk about reconstructive surgery. There are three items. Number one is the trauma, and it was divided into the A is acute trauma, and B is a traumatic deformity. And then the second one is congenital anomaly, and then it's tumor. Here we start to talk with acute trauma. I will present mostly with the case example so that you will have more understanding what I'm going to do. Here is a very severe crush injury over there, including the orbit, the zygoma, maxilla, and the soft tissue. So we do the primary reconstruction craniofacial. That is the bony part here, the orbit, the zygoma, and the mexa. And then we do the permanent closure of the subtissue, including the upper and lower edit, and the ductal metatarsus and the middle cancer ligaments. Here's the final result. Close-up view here. Normalize of the function of the lacrimal system and the eyelid. The second case, the same severe crushed injury over there, including the area, frontal, orbital, and nose, and zygoma, and mexa area. So we do the micronization approach to this area. See, you can see that here, crushed and depressed fracture over the frontal sinus orbital wall. We are going to go inside to take a look what's happened there. So we do the craniotomy assisted by the neurosurgeon from there to have better approach to the area. You can see here, when you take out the outer part of the frontal sinus, we can see that the inner part of the sinus also fractured, and injury to the brain and the epidermis. So neurosurgeon come in to do the repair and debridement over there. Then we pick it out all the bone, let the sinus go open, and then we do the outside work, do the primary repair, reduction of the frontal sinus orbital wall with wiring, and then we go ahead to do the work there because they are fractured and depressed to the nasal bone area. So we are going to do the morning work of the bone or the nasal bone. Here we do the cavalier bone graft, that T-shape. Here is a nasal on the nasal part. Here is the columnar part. You can see the columnar part. We do this bone to go into the area and with wiring for fixation. And this is the final result. 6 months after surgery, the nose and the frontal area and the zygoma and the orbit become normalized. The third case is a gunshot injury directly to the area, and including the bone and subtissue and the teeth. So we make a wide opening for better check up and do the primary reconstruction, including the bone and the subtissue. Here you can see the mission of the bone and teeth. And so first we make a bony work, repair, reduction, stabilize with plate and IMF. Then we use the comfort to close the subtissue defect of the mouth floor. And then we do the bony graft from the iliac bone and become curved and to grafting over there, and with some chip bone for better bone grafting. And here's the final result. 1 year after, the occlusion is okay, and he's actually shoot the press still there, and the stabilization of the bone, and he's outer looking normalized, and the sky is minimal there. Then we proceed to the traumatic deformity item. Here you can see the traumatic deformity and become deviated and depressed bone and deviated orbit there. So we do the capillary bone graft to reconstruction of the bone part of the nasal part and do the reduction and relocation of the orbit and the soft tissue. And this is the final result here. You can see that. You can see that. Another case is same here. Very severe crush injury there, and so become the deformity of the nose, the orbit, and so we make totally reconstruction of this area, and this is the final result. And you can see that here. The eyeball and the nose are in its good position. Now we proceed to do the TMJ ankylosis case. This girl had the TMJ had the right condyle fracture during her childhood, and so become the because of the she did not make a good surgical correction of the condyle fracture, so become the TMJ ankylosis over the right side. So during her development, her facial growth become underdeveloped there. So the mandible shift to the right side, and this after surgery, total correction. And this picture shows here the ankylosis over there, right side, but left side of normal, and the bone shift to the right side. And we do the total correction. First of all, we do open the right TMJ area with a pre-auricular incision and make an osteotomy to make an opening of the right TMJ joint area and take it out all the ankylosing bone and replace with the rib cartilage, and then do the OGS there. That is the follow one osteotomy, maxillary, and BSSO over there, including the genoplasty. And her tender approaching head opening before and after surgery. One finger breast, 3 to 4 finger breast after surgery, and before and after surgery. Now we proceed to do the congenital anomaly. The most common occurs is the crab-dip crepatic. Here is the left unilateral crab-dip and after lip repair. And this is the bilateral crab-dip and after bilateral chiroplasty here. And the crepatic after parodonticity here. And it's the credit patient when he grow up and become adulthood. Is a crepatic face, that is retreat mid face and mandible prognosis. So we do the tutorial surgery become normalized of her bone structure. Is the before and after surgery. And the lateral view before and after surgery. What we did is the advancement of maxilla by the full one and setback of the mandible by bilateral BSSO, bilateral central split osteotomy. If you can see the default one advancement and the setback of mandible by central split osteotomy. And the picture shows advancement, the maxilla, setback of the mandible, and also to the genoplasty. And her dental approaching, class 3 malapproaching, and the approaching become normalized. And another case is crab-dip face hypoplasia. You can see here. When the patient become adolescent or become adulthood, usually the crab side, face, or cheek will be hypoplastic, and so patient will come here to require for a cosmetic reconstruction. So at the time, I went to the bone graft to there. See, you can see the yellow patch shows where I do the bone graft. I do the cheek here and also do the upper lip, because an upper lip a little bit hypoplastic here, and sometimes the bone. I will do the nose, because usually the nose will be big and not so well developed. So I will do the bone graft over there. So you can see here, before and after surgery. So the face becomes symmetric, and become normalized. And this is the facial crepe bilateral. So will do the facial crepe repair and before and after surgery. Then we proceed to the tumor item. The most common bony tumor is fibrous dysplasia. You can see here, bilateral, the tumor located here, and also there. That is maxillary and the lower part of orbital and the nasal part. And this is her picture. You can see the tumor mass there. So we will have the protruding out of the nose and the orbit, and the eyeball will tilt up to there. So we are going to take it all out. We approach from the intraoral approach and take out all the fiber dysplasia out, and then we do the primary reconstruction with split rib graft. Do the framework over the floor. So this final result, 6 months after surgery, and his pictures, his outlook become normalized, including the eyeball, the zygoma, orbit, and the nose. Another common tumor for soft tissue is neurofibromatosis, neurofibroma here, and the treatment is taking out all the soft tissue, the media epicanthosis and eyelid. This is the final result, and I will show you how I approach to do the resection. Here is a tumor mass here. I sketch out, and I do this here. This way to do the medial epicantoplasty and do the incision here, and there for better resection of the soft tissue. And then we proceed to do the skin cancer here. These are old patient with a very extensive basal cell carcinoma there, and we do the wider resection to taking out all the skin cancer and tip to the muscle there. Then we do the cheek flap, big cheek flap for rotational flap to primarily close the soft tissue defect, and this is the final result. You can see the skin flap survive well, and no distortion or destruction of the other area, and no more skin cancer recurrence. This is 1 year after surgery. Okay, then we proceed to the unusual giant heteronemus growth here. So we are going to take it out and do the forehead flap for closure or the skin defect. So we do the tissue center over the forehead area. We do that by coronal incision and insert expander. And we expand the forehead for 3 months and preserve more than 3 months, so totally 6 months. And then we take out the giant heteronemus and make the forehead flap to rotate it down to close the skin defect area, and then we do the division. All. So it's the final result here. You can see the normal, the heteronemus, and the function. The function it becomes just a good and normal looking of the area here. Okay, the above part is the reconstructive part. I finished the upper half. Then I'm going to proceed to the second part, which is the aesthetic surgery. And there are 2 items for the aesthetic surgery. One is facial contouring. The second one is facial rejuvenation by fat grafting. Let me talk about the facial contouring first. Here is the facial contouring. There are 8 sub-items in the facial contouring. That is mandible precision or resonance. Second one is the maxillary pronunciation or resonance. Third one is the facial asymmetry with or without heavy mandible hyperplasia. Then is the maxillary protrusion, and then is the malar prominence, prominent mandible angle, prominent or research chin. And last one is nasal maxillary hypoplasia. That is Minter syndrome. I will talk about each case, each item. The first one is the mandible pronunciation. It is before and after surgery. And what we did is a setback of the mandible and become the midline replacement to the midline to the direct midline, not deviated. Here, the crossbite and crossing occlusion and do the central split or sclera. And then setback, taking out the bone and the fixation with wire or prep. This is the X-ray before and after surgery. And not only the setback, but also sometimes we will do the follow-one, the further osteotomy. So you can see that the follow-one and BSSO. And another case, before and after surgery. Before and after surgery. And the second one is the mandible recognition. Here, before and after surgery. Before and after surgery, what we do is the advancement of the mandible by BSSO. And before and after surgery occlusion. Here, central split osteotomy and fixation with wire or midbrain. And before and after surgery as well. And the following set item is the maxillary proclamation. Here, maxillary proclamation, and before and after surgery. And what we do is the setback of the maxilla by default one osteotomy. Here, before and after surgery. Before and after surgery. The surgery here. Default one and take out some bone part. So the setback and the relocated. And the the following item is maxillary rejuvenation here, and before and after surgery. And what I did is the advancement of maxilla by default one osteotomy here, before and after surgery, and fixation with implant and screw, and just X-ray finding before and after surgery. Before and after surgery. Dental occlusion before and after. And the following item is the facial asymmetry. Here is the case. The mandible and the macula shift to the left side because of the right condyle neck hyperplasia. So will be the ramus is elongated, so the mandible will shift to the left side, and also the maxilla will rotate to the left side. So what I did is doing the taking out the hypoplastic condyle neck and do the OGS over there. That is VSSO, dinoplasty, default one, labeling. That's it. So this is a picture, actually a picture finding here. Such as pre-osteotomy and take out the orbital neck and head, and shortening of the ramus here, and fixation with a wiring, and this area BSSO, and this area dinoplasty, and the default one, and fixation with a plate. Before and after surgery. Here, before and after surgery. Tender approaching, perspire and castration, and before and after surgery, and panoramic X-ray here, before and after surgery. And then we proceed to the next item is bimaxillary protrusion here, maxilla and the mandible, before and after surgery. And what I did is setback, Wasman or settle, setback the maxilla here to here, and setback the mandible anterior segment. Take it out one teeth bilateral, and setback before and after surgery. Here you can see more clearly, taking out the teeth and the alveolus, and osteotomy here, and setback and closure with IMF and wiring. Or sometimes you can see with the plate, mean plate. And the second item is the malar prominence there, before and after surgery bilaterally. What we did is a reduction malaplasty by coronal or by pre-auricular area, and by intraoral approach to make a reduction of the zygoma there. Before and after surgery. Another case, before and after surgery. Before and after surgery. There, normalized. Okay, we proceed to do the prominent mandible angle here. Usually we take it out, the morning part, preserve the subtissue. So we will cut here. Sometimes we will not only cut here, you also cut here. To become a shape cutting. You can see here. Here, we are going to take it out, the morning part, this area. So before and after surgery. But be careful to preserve the inferior alveolar nerve there. Before and after surgery. Usually we don't need to take out the muscle part, because the muscle will naturally be disused. So don't need to do the muscle part, just take it out more. It's okay. Here, before and after surgery. And another item is a retracted chip. Here, retracted, and we advancement, dinoplasty advancement So it's a before and after surgery. Here, the chin being advanced. Here, you can see that. First here, advancement. Here, you can fix with the wire or minute. And sometimes you can do the two steps advancement here. And it's the one case before and after surgery. And the last one is nasal maxillary hypoplasia here, before and after surgery. Before and after surgery. What I did is nasal bony reconstruction and bone graft over the paranasal area. There. Okay, this is the first item for aesthetic face surgery. And we move to the last one, is facial rejuvenation by fat grafting. This is not a common fat grafting we usually doing. It's the new one. I use the fat grafting to change the new facial shape. Through the facial shape changing, you can make the face become useful looking. That's a facial rejuvenation. So it's a new concept for fat grafting. That is my topics. The conceptual oriental facial rejuvenation by fat grafting. I presented last October during the Taiwan Society of Aesthetic Plastic Surgery. It is annual meeting. Let me show you what is this concept. This is the aged face shape. Here is already her face shape, not this way. It's called reverse overshift. Well, and the label is the eye label. Above is head, below is a face. So the cap of this face shape is a small head here and big face here. Small head and big face. Whereas the child and young girl, their face shape is this one. The younger is it's called overshift. And the character of this the face shape is a big head. Here, the big head. And here is a small face or V-shaped face. V-shaped face. So the comparison of the face shape for old and young female is reverse overshift to overshift face. So the goal of facial rejuvenation is trying to change the reverse overshift to the overshift. So the face will become useful, no matter the eye, nose, or mouth, or the nasopharyngeal area forward. You don't care the inside part. It just the outside face shape is the focus for doing the facial rejuvenation. And how to do it? The goal approach is a four-phase autologous fat grafting. The character of four-phase fat grafting is the following: 4 big head changing procedure. Is using fat graft to the forehead and the bilateral temple, so that the head will become big. How to make a small face? we use the fat grafting to the central line of the face. That is the glabella, nose, medial, sometimes lateral, cheek, and chin. And so that when you do the bone graft, the midline area, the face will become smaller and become elongation, sagittal. So that is the longer face length and narrower face width. That's called sagittal centralization. So the face will become smaller. Here you can see more clearly. Here, the small head, when doing the bone graft, fat graft will become big head. And that big face, when doing the fat grafting on the nose, medial cheek area, chin, sometimes occasionally we'll do the lateral cheek here, so that the face will narrow and become elongated. So become smaller face. Let me show you with some case example here. Before, after doing the fat graft area here, and after surgery, 3 months after surgery. 3 months is stabilized of the fat survival. So 3 months is usually we want to make a definite result for measuring is 3 months. So become big head, small head, become big head, big face becomes small face by fat grafting over there. Forehead, bilateral temple, nose, chin, medial, cheek area, and sometimes lateral cheek for evenize, smoothness of the face shape there. The second example here, before, after, through the fat graft over there. Forehead, bilateral temple, so become small head, become big head. And nose, chin, medial cheek, it's the same. Occasionally, a little bit fat graft over there, so become big, become smaller face. Another example is before, after, through the fat graft over there. The key, the success key point of this procedure is two-stage procedure. And its interval is 3 months. Why 3 months? Because 3 months is the stabilized of the fat graft. And why need 2 stages? Because only 50% improvement for each stage. So it's necessary need 2 stages for patient satisfaction. Let me show you the 2-stage procedure. Here, before surgery, after first stage, 3 months after first stage, and 3 months after second stage, you can see the change. 50% improvement is about 70 or 80% improvement. The second case, the same. First stage, second stage, 3 months each. So it's a 50% improvement and 70 or 80% improvement. Big head and small waist. The example 3 here, before, after the first stage, after second stage. Not only the face shape change, you can see the skin texture. Skin texture will change too, become useful. You can see the change, the difference. I mean, let me show you another case here. The skin, you can see change. You can see the change too. Why skin change? Because of stem cell. Adipose derived stem cell will have its function usually after 6 months of fat grafting. The skin will become younger because the texture will change better. Okay, in conclusion, today my topic including the reconstructive surgery and aesthetic surgery. Reconstructive including the trauma, congenital anomaly, and tumor. Aesthetic including the facial contouring and facial rejuvenation by Fat Grafting. I thank you for your attention.
Thank you, Professor Tsao, for the very extensive lecture and a great overview on all the topics that we would probably deal with in craniofacial. And at this time, I would like to invite Dr. Tsai for a few comments. Dr. Tsai?
Okay. And thank you, Professor Tsao. It's a very nice and excellent lecture from us. And I want to ask one question. It's about how do you learn from trauma and to use to improve the aesthetic surgery? It's made most important for us because for the young staff, we all learn from trauma, but I don't know how we to apply to improve our aesthetic surgery. Because you are the senior, can you tell me the some secrets from the trauma surgery to improve the aesthetic surgery? Thank you very much.
No magic, only basic. It's an old saying, but it's true. From aesthetic from reconstructive to aesthetic is a global trend.
Yeah.
When you are young, you will do the reconstructive surgery, that is the bony part. When you become older or more seniorly, we will shift to the soft tissue part. So not only the bony part, but also the soft tissue part, you are necessary to learn to get better result.
Mm-hmm.
And the bony part is the basic and it's most important. When the trauma or traumatic deformity happens, you need to do the reconstruction to become the normalized or the bony framework. But it's not enough because soft tissue part is another very important part because patients they did not see the bony part. Only they can see is a soft tissue part and the skin part. So you need to pay attention to the soft tissue part only. Also, that is why the cranial surgeon, when she or he become more mature, he will pay more attention to the soft tissue part. That is from the reconstructive to the aesthetic or cosmetic surgery. That's why they are going to learn and they are going to do such kind of work. So as a young surgeon, first of all, we are trained by bony. But when we are growing older, especially when you over 40-year-old, you need to change to the aesthetic part. That is the training course, and that is a natural course.
Thank you, Professor Tsao.
Okay, and at this time, I would like to invite Professor Low for a few comments.
Hi, Dr. Tsao, thank you for your talk. In the beginning, I have a comment that I'm so happy to see you again, and Dr. Tsao is my senior, and actually I learned from him when in the beginning of my career as a practice surgeon, and I think all the audience can notice that Dr. Tsao's background is craniofacial surgeon. I think a craniofacial surgeon know very good anatomy, facial skeletal parts, soft tissue. So when you do the no matter reconstructive or aesthetic procedure, you can do it, with confidence, and you have no doubt that easily perform the surgery and as you wish. So I think for the young surgeon in the audience, I think the craniofacial training is very important. If you can know very clear bone, soft tissue, then you do even cosmetic procedure it is easy for you. And that is why Professor Tsao can do very wide range of the surgical procedure, including trauma, congenital, tumor, or developmental, and from reconstruction to aesthetic field. Very nice. This is my comment. So I wish that for the young surgeon, when you rotate to craniofacial team, you should enjoy the training in craniofacial team. And for that, I would like to thank Dr. Tsao again during my training years. So, and the second is I wish to ask you two questions. One is that you move from medical center to private practice, and this is a very different environment. I don't know how you adjust yourself to, to a private environment that you may only do a small portion of the craniomaxillofacial part, or you do many parts as before, or you have some kind of selection in your private practice. Professor Tsao.
Thank you for your question, and thank you for giving me a chance to say more about that. Yes, it's very interesting. That not only to me, but also to me, and not to you, but also to me. I have my own private practice when I was 45 years old. 45 years old is very old for patient, for doctor when he was going to practice. It's better 40 years old. But at the time, that's 25 years old, I think it's okay to me. And I'm happy to have my private practice because I also do quite a lot cranial maxillofacial surgery when I was in my private practice. So many of the cases of the OGS I do in my clinic, not in hospital. And I follow the principle of day surgery, the American standard. Most of the cases I don't overnight to my patient. I just finished my surgery and the patient going home during the same days. As of course, I have good equipment and including the anesthesia equipment, and have good anesthesia doctor to help me, so I can take it out the IMF, so patient can have good airway protect, so they can come home. So I feel very sad due to the maxillofacial surgery when I was in my private practice. But I don't do the preparate because it's insurance cover. I will.
You can refer the patient to me.
Yes. yes. I refer the patient to our fellow in Chang. When patient come to see me, I just take it out. I just go back to Chang. I only do the data part. That is crepic deformity, not the crep. It's something about the lip revision, nose
secondary deformity.
Secondary deformity. I just do that because it's not insurance by not it covered by insurance. So that is what I did, and also of course I do many cosmetic cases because I found many patients they don't come to the big hospital to do the cosmetic surgery. Most of the patients in Taiwan for cosmetic surgery, about 80%, they just doing the surgery in the clinic, not to the hospital. This is a situation not in Taiwan, but all about the world. United States, Japan, Korea, the same, because the efficacy and privacy, they concern the privacy and efficacy for cosmetic patient, so they ship to the clinic. So in the Chang'an, we cannot do many cases, so that many patients cannot get good doctor to do the surgery. So that's one reason I want to have my private practice in my clinic, because I set up the second center, cosmetic center in Taiwan. Yes, one is in Taipei. Our teacher Dr. Nodo set up. The second one is me set up in Hong Jong-Chen. But even I set up the cosmetic center in Hong Jong-Chen, only a few patients, cosmetic patients, come to see us. So I feel very frustrated. We like to do the cosmetic surgery, but we cannot do that because patients don't come to us until they are destroyed by the quick or unqualified doctor. So they come to a big hospital for give some help, but we cannot do many help because their nose or their eyelid or their breast are destroyed. It's not easy to reconstruct or easy to make the beauty. So that's one of the reasons I want to have my private practice. And I do many patients there, and I feel happy. I can help them by first hand, not by second hand. And it's not difficult to do the private practice. It's not difficult when you have the very strong in mind in your technique, especially our craniofacial surgery. It's very good for us as a craniofacial surgeon. You can do very nice cosmetic surgery on your face because we have very skilled hand, and we know very a strong technique and knowledge to the morning work and do the facial work. So it's good for us to do the cosmetic surgery on face, not only in big hospital but also in the clinic. So I found there's no difficult. What you want to go to your private practice is not too difficult for us.
Thank you. I also would like to mention that Dr. Tsao, although he is very busy in doing private practice, but he is also very academical. He is collecting data, writing article, publish paper, and also review article. So, and also provide service in the society. So to me, he is very energetic, very, spend a lot of time, not only in the private practice, but also in the academic part, and also the social responsibility part. So he is a very good model that we can learn from him. Dr. Tsao, let me ask you another question. And I actually enjoy your talk about the whole face fat grafting. And I think I saw your patient's demonstration, and this is quite a nice result. So here is the problem here, or question that, number one, how much fat do you use for the fat grafting? You mentioned the area in the central part, so-called sagittal, the sagittal portion that you wish to make it fullness, so it look more useful face. So this is the number one question: how much in the 2 stage? How much fat do you use for injection? The second is that how do you choose patient for fat injection or for traditional facelift? Do you still do facelift, or you just now shift to fat injection? I would like to hear your answer.
Thank you. Very nice. Two questions, very important and nice. And I'm happy to answer you. The first question is 30 to 50 cc. 30 to 50 cc for face. I will the patient to choose the area they are going to do the fat graft, such as the forehead, the temple, the middle cheek area, and the chin and the nose. Usually I will tell them if you do this area, your face will become small and your head will become big. So for other patient will allow and agree my concept. They will change their concept to do the fat graft, not do the facelift. I do another facet. I'm the specialty for facet, but more and more I change to the fat graft first. I think the fat graft, if you do the fat graft, it's cheap, it's safe, and it's you can get the quite the same result as facet. So I will change. I will persuade my patient to do the fat graft first. After fat graft, 2 stages. Most of patients, they don't like to do the facet, and that at the situation they will save money and save the safety, and patient will happy. And patient will happy. Another one is their abdomen, their stomach become more slim or more good looking. Also patient happy. And another one is more easy to do the surgery. No, very low morbidity or mortality. And firstly, you will pay many attention to do that. And it's a high tension surgery. But fat grafting is low tension surgery. So most of the time, well, I do the fat graft first. And another one is even you do facet, you still need to do the fat graft. They don't. Because facet just lift up the face, but they don't add the face there. They are soft tissue atrophy. This is still there. When you're getting old, not only the tissue drop down, but also the atrophy of soft tissue. So you need to do the fat graft later on. So that I will change the sequence. Do the fat graft first, and then do the facet later on when patient getting older and older, and when the fat graft disappears gradually. Usually the fat graft will still there for 3 to 6 months, 3 to 6 years. They was there. After 6 years, if they want, they can do regraft again, or they can do change the facet at that time. Sometimes we have to do both together, facet and fat graft. Facet there, fat graft there. In the central part, I do the fat graft, and I do the facet lateral part, so that we are composite procedures. It will depend by patient need.
Thank you, Mike. Thank you very much. Very good answer. Junior, back to you.
Okay, thank you, Professor Lo. And at this time, I would like to invite our next moderator, Dr. Hong Jong-Chen. Dr. Chen.
I'm here. Dr. Tsao, thank you for your wonderful speech. You are the role model of our young generations, and you demonstrate how to improve the aesthetic surgery outcome based on previous reconstructive treatments. And we are all aware that you now have your own aesthetic clinic and specialize in cosmetic surgery, and you are very, very successful now. And could you please explain why? And at the age of 45, because I'm 43 now, and you choose a medical center and take a career as a cosmetic surgeon. Would you leave medical center earlier if you have a second chance? And can you show our young generation why you want to leave the medical center and do cosmetic at this age? Do you have something interesting story can share with us? Thank you.
Thank you for your question. You mentioned this. I would like to talk about this question. It's very important to our practice surgeon. That is what time do I have to do majorly the cosmetic surgery? And you know, there's a cross. The cross that is from reconstructive surgery shipped to the cosmetic surgery. That's a cross. That's from the beginning we do the reconstructive surgery. Gradually, when you're getting old, you do this and this reconstructive surgery because it's very you cannot do the so many hard work all the time, so you are getting those and those. And another one is here, upward, that cosmetic surgery. When you young, you do this and this cosmetic surgery. Then you are getting old, more and more cosmetic surgery. That close is about 40-year-old. That is close about 40-year-old. So 40-year-old is a turning point. 40-year-old is turning point from reconstructive surgery to the aesthetic surgery. That is a global trend, not only in Taiwan, but also many the Japanese, United States doctors, they do same thing. When you get old, I do both. I tell you that when I was in the Miami, Jefferson Memorial Hospital, I learned from the Minard. Minard is a pioneer of the critical palate. And he do both. He do the critical palate surgery and he do the cosmetic surgery. And his cosmetic surgery is do in another hospital. And he will bring his cosmetic patient to another hospital. And he has his own clinic. His own clinic is just about 100 meters distance from the Jefferson Memorial Hospital. So it's very interesting. He do both surgery, and he told me to. When you're getting old, you need to do more cosmetic surgery, not only the reconstructive surgery, but he can do both because he's a pioneer, he's a president, he's a chief, and he's a professor in Jefferson Memorial Hospital. So the Jefferson Memorial Hospital allow him to open his own clinic outside the hospital. And this gave me very shock when I was there. At that time, I'm 35-year-old. I learned the Millard palate and Anthony Wolf. Anthony Wolf is another doctor in the Miami, in Jefferson Memorial Hospital with Dr. Millard. He's a craniofacial surgeon. There's relationship that the Dr. Nodov and the Dr. Chang. Yes, it's a Dr. Millard is a different critical palate. That's Dr. Nodov. Anthony Wolf is a cranial surgeon, and Dr. Chang. They are stretching, and they both have to the clinic. They own the clinic to do the cosmetic surgery there. It's very interesting. And so about around 40-year-old, you have to have the mind to you need to do the more cosmetic surgery because your body is losing your body weight and your strength is losing, but your knowledge is still upcoming. So you need to do the more delicate work. That is the cosmetic surgery. So aesthetic cosmetic surgery for our cranial surgery is very nice way to go. So it's about 40-year-old. But you can wait longer than me, 45-year-old.
Thank you, Professor Tsao. Thank you.
Thank you, Dr. Chen. And at this time, we would like to go to Q&A if the time allows. Professor Tsao, is it okay if we ask a few questions?
Okay, no problem.
Okay, our first question is from Dr. Pitch Vandit. Dr. Pitch Vandit, would you like to ask Professor Tsao the question that you have?
Dr. Long?
Okay, I guess Dr. Pitchventer would like me to ask the question for him then. Okay, so his question is that you presented a case on Mustarde flap, and he would like to ask you, how do you close the skin around the pre-auricular area after you close the defect, after you rotate the flap to close the defect?
Oh, yes, it's easy. When you rotate the cheek flap from here to there, you mean to how to correct the defect there, right?
I think that's what he was trying to ask.
Oh, yes. You can do undermine there. To undermine it there and do advancement. To do advancement of the soft tissue here and make a close there. There will no problem because you ship, it become big. More big is better. More big you can ship here. And the second effect, it will be no problem. It's no problem to close. You can use the soft tissue area, and after undermining, it will be no problem to make a permanent closure.
Okay, thank you, Dr. Tsao. And our next question is from Dr. VM, and he would like to comment that young surgeons won't have such a privilege to do everything at hand, so they will be forced to choose one aspect. In such scenarios, what would your advice? Should the young surgeon try to do everything or focus on what is available?
For young surgeons, they need to learn the basic technique. As a craniofacial surgeon, the first one is acute trauma. So we need to learn the craniofacial technique from trauma, because the patient, when get the trauma, the first important thing is save your life, the patient's life. So at the time we can set that and make our surgery, the bony work, even here, will be no problem to keep the bony framework intact or good reduction. So if even your technique is not so good, well, this patient will have the improvement of their bony work. So they will have no malpractice or medical legal problems. So at the time you can learn a lot of technique from the acute trauma. So that is the most important part is more acute trauma, more learn, more happy when they are young. But when they getting old and older, they will do the not only acute trauma, but also traumatic deformity. At the time, the patient was deformed patient. They are not normal patient. They need your help to make their face become normalized. They don't want to become aesthetic appearance, just want normalized. So even your work is not so good enough, if you have some improvement, patient will happy. So even acute trauma or traumatic deformity, that case is very big case. Very big case because of traffic action everywhere. So you have many cases to learn your technique, to learn your skill, to get many experience. Become the experienced hand at that time. So at the beginning, the beginner 5 years is the best time to do the traumatic work patients, and then shift to the congenital. Because congenital is still is a unnormalized patient, such as the crippling and that's a skin cancer, that's a soft tissue tumor, soft tissue or fiber dysplasia tumor cases. This is a disease and insurance coverage, so you can do such kind of work, no problem, no medical legal. So finally, when you matured after 40-year-old, you can shift to do the full-time cosmetic surgery because it's dangerous, more dangerous than everything. Patient will shoot for you if you do not good work. So not so. When you want to have your private practice, should be very careful. Should be after 40-year-old. Before 40-year-old, many legal problems. At the time, I'm in Kaohsiung. I am the medical legal problem mediator. I'm the mediator in the government. I saw many medical cases, medical legal problems. Most of the cases are young practice surgeons, even our member. So I feel many effort to persuade the patient and persuade the doctors not to do the bad scenes. And because they are young, usually they are before 40-year-old. So young to do the cosmetic surgery will be a disaster to patient and to doctor himself. So it's better to wait until 40-year-old do the cosmetic surgery. That's my answer.
Thank you, Professor Tsao. And for our last question, it's from our very own Dr. Zhou. So Dr. Zhou, would you like to ask the question yourself?
Oh, thank you. Thank you, Professor Tsao. I saw a lot of your cases, the patient receiving the OGS, but by your time, you have, I think you have no the KCAM assistance. So how is your method to identify the intraoperative the beauty by your own eye or by your own experience to judge how to put the upper jaw and lower jaw at what place? Yeah, so I am wondering what is your method to judge the beauty intraoperatively? Yes.
I have another assistant in my clinic.
Okay.
Yes, so we have two surgeons.
Yes.
He's a plastic surgeon too. He trained from Kesey General Hospital. Dr. Lee.
Oh, yes.
Yes, he's my student. Then is my partner.
Mm-hmm.
So we do two surgeons, not only me. So
Okay.
we can do we can have the to decide which one's better, which one not so good.
Okay, I understand.
Yes.
Very good. Okay, thank you, Professor Tsao. So any questions from the audience from the ICC webinar? Okay, I think time is almost limited. So yeah, I would like to invite all our audience to show you a smile, and you can turn on your screen with us. And I have to pay my greatest gratitude to Professor Tsao today. I learned a lot, especially for the suggestion in the middle age, especially for the question from the Professor Hong Jong-Chen. Actually, I am the same age with Dr. Tsai and Dr. Chen. So I think in the Chang system, it's not allow us to open another private clinic very nearby to our hospital to work at the same time. It's impossible. So we are so jealous about all the doctors in United States. Actually, yes, I think the cosmetic surgery is very important in our age. So I cannot say what is our future will be, because our mentor, Professor Low, is here. I doubt he will be very worried about our future. So, so I really thank you for Professor Tsao's today's suggestion. Okay, so I would like to invite all of you to show your smile with us, and I will count to 3 to have your smile in the same page with Professor Tsao together. So 1, 2, cheese. Thank you. And then let's turn to the next page.
Thank you all. Bye-bye.
Okay, thank you. Thank you,
Thank
Professor
you.
Tsao. Okay, thank you. Good morning.
Good
and
night.
evening. Have you next time. Thank you very
See
much.
you. Okay.
Bye-bye,
Thank you.
bye-bye.
Bye.
Bye.